Okay, so it's an election year, so we thought we'll do our own debates as well. And I have to say, I get nightmares about this part, especially when we invite two of my very, very dear colleagues. If anything, Dr. Anthony El-Khoueiry, fellow Lebanese as well. And Anthony, you should meet, by the way, Bruce, who was born in Beirut. And Anthony is from the University of Southern California, really a key leader in regard to the hepatobiliary arena, and has contributed quite a bit, especially on the SWAC platform, and obviously part of the task force for hepatobiliary as well. And also a very dear person to me, also Dr. Maeve Lowery from Memorial Sloan Kettering Cancer Center. Maeve graduated from Ireland and did her fellowship in advanced oncology and GI at Sloan Kettering, and now is a member of the faculty. And that's why I get nightmares, kind of like put two very dear people in kind of debating a quite challenging component of the discussion. But nonetheless, for molecular profiling for the EA is actually Anthony who's going to talk about, for the NA, you're going to talk about the needle in Haystack, and maybe we should look more as a bulk therapy, and then Maeve will try to oppose that by talking about that this is the future for therapy. 20 minutes for each, and then 5 minutes to be fair to Anthony to get a rebuttal, and then questions and answers. So we'll start with Anthony. Thank you.
Thank you, Ghassan, for the kind introduction, and thank you for the organizers for inviting me, and congratulations to the Cholangiocarcinoma Foundation on the continued growth and success. I'm working against several challenges today. I come from Los Angeles, so seeing snow outside and being below 70 unsettles me. But the bigger challenges are I'm neither a basic scientist nor an expert in molecular profiling. So I guess the way I will approach this topic today is from the eyes of a clinician who is trying to move the needle forward in this disease. So when we talk about molecular profiling, the end goal there of doing all of this from a clinician's perspective is the application of personalized medicine in a challenging disease. This becomes possible now with the molecularly targeted agents growing day by day in number and new targets, and the advances in high throughput technologies. So there is promise there, but there are many challenges, and this will be the focus of my talk. First, if we look at the initial attempts to incorporate targeted agents into the therapy of cholangiocarcinoma, and this is one of many tables that you can look when you look at review articles. You could create your own. But the bottom line, there is really nothing that really stands out here as far as outcome. Now, I submit that these are unselected patients, mostly all comers. But even when investigators have tried to look deeper, for example, in combination with cetuximab or panitumumab, and focus on patients with wild-type KRAS, still the outcomes were not very different. So I'll start by talking about general challenges of tumor profiling. And many of these are familiar to all of us, but I just want to kind of put them all in one list over the next 2 to 3 slides. So the more the technology advances, we continue to face the challenge of defining what is a driver alteration and what is a passenger alteration in the genome. This gets more complicated when we have multiple alterations in the same tumor or the same patient. Other topic has to do with technology. We frequently, especially so far in cholangiocarcinoma, have focused mostly on DNA mutations. And we've used different panels to look at this. But are DNA mutations, especially in single genes, sufficient to improve the care of patients? Are these, again, mutations drivers? And do we know the functionality every time? Is it better to look comprehensively, include RNA and protein? And of course, some studies have done that. What about chromosomal aberrations? Then if we look at biopsy samples and depths of sequencing, these are other challenges. Frequency, when we biopsy these lesions, we get normal cells as well. there are multiple clonal subpopulations within the same tumor, which I will come back to as well. If we think we have a driver alteration and we establish the deleterious effect of that alteration, that still doesn't mean that that alteration is a biomarker of sensitivity or resistance. And we as clinicians frequently mix these up. So having a functionality defined doesn't mean that we can necessarily select patients based on that alteration. We can also, because of the complex biology of this disease and others, we always have to account for downstream alterations of the target. So we may look at EGFR, but alterations in downstream pathways such as MAP kinase, PI3 kinase may drive the biology more than just targeting EGFR. There are always alternative signaling pathways, so targeting one usually leads to upregulation of the other and the creation of resistance. The other challenge, which is really beyond my expertise, is let's say we do well and molecularly profile these tumors and we want to put this into application in a clinical trial. Well, how do we prioritize these molecular alterations? So people who are much smarter than me published this in JNCI this year as a guide to these molecularly targeted trials. And without going through this in excruciating details, but there are some common themes here. So we have to classify the targeted pathways. What is a bigger driver in this disease or this setting? Is the alteration a direct target of the drug, or is it an indirect biomarker in the same pathway? Is it an oncogene activation or a tumor suppressor gene inactivation? And which one is more important in that disease, in that patient, in that setting? Is it an activating mutation versus focal amplification, etc.? So, and it gets more complicated when you have activating mutations in more than one oncogene. And there you have to take into account things that are more complicated, such as the frequency of the mutation, the depth of the mutation, and other validation of the functionality, etc. So this is quite complex, and yes, it holds promise, but all these challenges have to be sorted through. Then when we start looking at the tumor, especially in cholangiocarcinoma, the issue of tumor heterogeneity becomes also another challenge. There are a couple of types of heterogeneity. One is the spatial heterogeneity. So it depends where we do that core biopsy and what part of the tumor we sample. Also, are we sampling the primary tumor or a metastatic site? And this also has to do with the clonal evolution concept that we will come back to. And then we sometimes drive heterogeneity by using targeted therapies or even chemotherapy sometimes, and heterogeneity evolves over time as the patients are being treated or new resistance develops. Subclones emerge either under the influence of therapy, such as here, or there can be de novo alterations that exist and again emerge as the pressure of targeted therapy is applied. Then we go back to the technology. When we biopsy these tumors, it depends which sequencing technology we're using, the sensitivity of it. The deeper sequencing has more coverage, which may account for rarer, less frequent alterations that may be important. Multiple sampling becomes important to again account for the heterogeneity. But another important concept that we need to really think about in the implementation of targeted therapies under tumor profiling umbrella in cholangiocarcinoma is the concept of circulating biomarkers, which allow us to dynamically monitor these tumors as they evolve. Let's talk about some of the targets in cholangiocarcinoma. This is my own summary table. Many of these publications are from people in this room, including Millind and others. And I didn't include all the genes that were published in each of these publications, but I chose some of the ones that we're more familiar with, that we look at more frequently recently, and that have been duplicated across the studies. Notice first the range of patients in each of these publications. They range from as low as 28 to as high as 200. Many of them are single institutions. Some are a few institution-wide. But that's a limitation in its own. Many of these studies are relatively small, and that, I think, contributes to some extent to the variation in the frequency of some of these mutations. When you look at IDH, for example, here is at 12%, here is almost at 24%, here's at 35%. Again, this is just for the sake of example and some of the challenges we face here. The platforms used in these different studies also were different. One of the other concepts that I want to mention, if you look at some of these genes, and I'll come back to some of these alterations, yes, we can see them, but can we target them? And what do they mean in the context of the other concurrent alterations in the same patient? Again, a repeating theme here. The next challenge we have in cholangiocarcinoma is that it is really not one disease. This is from Million's group where, sorry, go back. Where if you look at intrahepatic cholangiocarcinoma versus extrahepatic, yes, the numbers are small, but this is a repeating theme. The frequency of several of these alterations are different by location. So the biology, as we all know, of intrahepatic, or now we're learning more and more of intrahepatic versus extrahepatic versus gallbladder cancers are actually different, and therefore lumping them in studies and when we do tumor profiling can be quite a challenge. Some of the important differences are in genes that we are targeting recently, such as the FGF pathway, IDH, which seems to be mostly in intrahepatic cholangiocarcinoma, etc. By the way, the previous table I showed was only for intrahepatic cholangiocarcinoma as well. What about the etiology? Again, as we know, this is a disease where there are diverse etiologies, but there is a common theme thought to be in place, which is chronic inflammation. But this is an elegant study published in Nature Genetics looking at, I keep pressing the wrong button, I'm sorry. Looking at the non-infectious cholangiocarcinoma from different places in the world versus infectious-driven cholangiocarcinoma. And you see the differentially mutated genes listed here. So not only does the location influence the frequency of these mutations and their relevance, but also the etiology affects that biology as well. Again, looking at some genes such as IDH, which is detected in 14% of the patients in Singapore versus 4% in Romania. These are both in non-infected patients, but then in the infectious cholangiocarcinoma in Thailand, it's only 2.8%. And again, on and on for others without dwelling on this. Then if we look at the concept of biliary carcinogenesis, that seems to also be different for intrahepatic versus extrahepatic versus gallbladder. Again, here you see that there is nitric oxide, COX-2 upregulation, P16 downregulation, S100. Here there is KRAS early on, P10, and in gallbladder, again, some of the same themes with COX-2, but this is earlier, but P53 here pops up as more prominent, so does HER2, and other loss of heterozygosities. So even early on, the complexity and the differences amongst these tumors based on location start emerging. I alluded to this earlier. Some of the targets we are finding are difficult targets. We all know the challenges of being able to target a KRAS mutation. The strategy has been to go downstream at the MAP kinase or PI3 kinase pathways, again, with very limited success so far and no consistent signal. Same again with the AKT-mTOR axis as well. So how about moving away from this and looking more broadly and comprehensively? So using integrative molecular analysis and looking more broadly at alterations at the DNA, RNA, protein, chromosomal aberration levels, etc. Daniela Sia and colleagues were able to classify cholangiocarcinoma into two classes. One is a proliferation class, and one is an inflammation class. And you see that the genes involved in these classes are quite different. And the classes have different prognosis, with the inflammation class having a better survival than the proliferation class, which actually in subtypes of the proliferation class looks a lot more like HCC and thought to have a common origin. So I guess part of this haystack that we're talking about is that this is a disease where we may need to take a more global approach and look at subclasses rather than individual mutations. Even within each, the inflammation versus the proliferation subclass, there were several subgroups. For example, in the proliferation class, the P1 group was mostly, driven by KRAS, IGF-1R, and MET signaling. And this was a group that had a lot of poor prognosis signatures. The P2 group of the proliferation class had a lot of stem cell-like features and looked more like HCC. And again, the P3 group was more driven by EGFR. So it's interesting also when we start looking at individual mutations that these, within the context of these classes, seem to separate, and they're not the same across these classes. So what does it mean when we find an individual alteration in this bigger context? What about the microenvironment? If we look at cholangiocarcinoma, intrahepatic cholangiocarcinoma arising in a normal liver versus a liver that has a chronic disease, usually some sort of hepatitis or cirrhosis and chronic inflammatory condition, you see again that the genetic alterations are different in intrahepatic cholangiocarcinomas arising in normal livers versus diseased or chronically diseased livers. So, and again, you see some of these genes listed here, but even the relevance, the prognostic relevance of these alterations, such as KRAS, is different depending on the setting and the microenvironment where the cholangiocarcinoma arose. The stroma effect. We know that this is a disease with a hypovascular desmoplastic stroma with high infiltration by cancer-associated fibroblasts that promote tumor progression, produce growth factors, matricellular proteins, chemokines, etc. For example, hedgehog signaling also has been found to promote this desmoplastic reaction, so has Notch, etc. So these broader pathways may be relevant in this disease by targeting the stroma. And again, what do the individual mutations that we identify mean in this setting? It is unclear. The epigenome is another alteration that's important to keep in mind. Many more publications have been arising talking about epigenetic alterations in this disease. And this one is one that I'd like to highlight, which showed that the methylation of several of these genes was much higher in tumor versus normal tissue, and most of these genes were in the Wnt pathway. Again, a pathway that is thought to control stem cell differentiation. So let's look at some of the examples where we have used targeted therapies based on profiling. This is data that's fresh off the press, presented by Milene Javle at the GI Cancer Symposium in San Francisco just 10 days ago, and where we see a very intriguing signal with a reduction in tumor size in the majority of patients who have been treated with FGFR alterations. The challenges are going to be, this is early on, right? But this is a great signal. The challenge will be down the road, how long will this last? And in how many patients will it last long? So far, there's a good signal. We don't know how long this will last. We don't know if this will be sufficient, etc. But from my perspective as a clinician, I thought, well, how can I explain that this worked so well versus others maybe not working so well? I think one of the reasons is that there is known established functionality of the fusions that we see with the FGFR2 gene, and these have been associated with enhanced proliferation. There's a consistent body of preclinical work here as well. However, ultimately, these patients will progress, and many have progressed. So should we start thinking about the right combinations or thinking more about clonal selections, etc.? What clonal pressures are we applying through these therapies? What about IDH? Again, very early data targeting IDH1, but only 1 in 20 really had a PR. Despite all that we know about targeted therapies not really leading to tumor regression, whether consciously or unconsciously, we still look at tumor regression as an early sign of activity. And this is not a very high rate of tumor shrinkage. Yes, this is intriguing as far as stable diseases, 6 of them lasting 6 months or longer. So again, maybe an intriguing signal, but it looks a little bit different, again, with small numbers than the FGFR story. So why is that? Is it because for IDH, the functionality is defined to a large extent. It has a prognostic impact and associated with improved survival. But the biology here may be more complex, because IDH, again, has oncogenic effects for sure, but it has one of the papers that I looked at called survivalogenic effects with the improved prognosis. There's a complex biology where the IDH mutations arise in the setting of increased p53 mutation alterations and DNA hypermethylation, and how relevant the epigenetic changes in the setting of IDH mutations is still to be sorted out. There is a lot more interaction with other genetic events in the setting of IDH mutations. So is this why just targeting IDH alone may not be sufficient? Again, this is quite early, and I'm throwing a lot of hypotheses there, but to make us think through this. This is an interesting poster from Tony Saab's group, where they looked at the 2 exceptional responders to selumetinib who had deep partial responses on their trial, and did quite extensive profiling of the tumors on these patients. And in summary, what they said, this is straight quoting from their abstract: we did not identify any commonality in tumor-specific variants, novel and functional between the 2 tumor samples. No concordance in gene fusion and copy number events to explain why both of these patients responded to MEK inhibition, but several of the identified genes and their associated pathways are linked to MAP kinase signaling. So they hypothesized that alternate variants or mechanisms may be responsible for the clinical activity of MEK inhibitors, such as immunomodulatory effects, angiogenesis, epigenetic drivers. Again, I guess what I'm getting at is even when we do tumor profiling and identify targets, the story seems to be a lot more complex. So a needle in a haystack from Wikipedia is defined as a figure of speech used to refer to something that is difficult to locate in a much larger space. And I think this is truly what's happening here in cholangiocarcinoma. What I try to impress upon you is the complexity of this disease, with the diverse etiologies influencing the carcinogenesis, the impact of the host of the microenvironment, the epigenetic alterations, the stroma, and the stem cell pathways. But even if we get through all of this and we get to our molecular alterations, are they targetable and actionable? How do we prioritize them? There is quite a bit of heterogeneity within these targets, and the clonal evolution is another thing we have to grapple with. I'll stop here. Should we take questions now or move? Let Maeve, okay.
Good morning. Well, I have the lovely forward-looking title of Molecular Profiling of Biliary Cancers, the Future of Therapy. So I like that it's forward-looking, because really this is kind of an aspirational talk, right? And I think that Anthony set me up nicely by describing the complexity of genetic alterations in biliary cancers. And I would argue that isn't it really wonderful for those of us who see patients with cholangiocarcinoma, for those of us striving to get better treatments for our patients, to have these problems? Isn't it wonderful that we have found so many genetic alterations, so many complexities within different subgroups of our patients, that we have actually so many potential targets for therapy, that the challenge for us now is exactly, as he said, to sort this out, to identify patterns, and to find the real drivers in terms of therapeutic targets. So this is just an example, and you've heard some of this already, as to the real huge variety of different and complex genetic alterations that we see across different sites across the biliary tree. And we know from the clinic that different anatomic sites of cholangiocarcinoma, differing to gallbladder cancer, behave differently in a clinical fashion. And now we know that they also have different potential molecular drivers and different molecular characteristics. So a wealth of well-done, mainly retrospective, but extremely comprehensive sequencing studies which have shown us that there actually are some unique molecular features to cholangiocarcinomas arising in different sites in the biliary tree. This large study from Japan, over 200 patients, where again we see the pattern previously described, that FGFR2 gene fusions appear unique to intrahepatic cholangiocarcinoma. IDH1-2 mutations likely enriched for in intrahepatic cholangiocarcinoma and rarely identified in hilar or extrahepatic cholangiocarcinomas. And then a wealth of other potentially targetable alterations in intrahepatic cholangiocarcinoma, including some sort of particular mutational signatures that maybe would hint to us that the etiology of these cancers also is different. In extrahepatic cholangiocarcinoma, some novel fusion events identified in this paper and in others potentially targetable, and mutations also in ARID1B, ALF3, somewhat associated with maybe a better prognosis. So with this information, can we now use this both to sort patients and identify which molecular driver is most important in a given patient or a given site of disease? And can we also infer potentially some prognostic information in terms of response to therapy, but really in terms of overall survival? And importantly, can we work backwards from this? Can we identify what the molecular drivers of carcinogenesis in a given patient are? And can we associate them with different environmental exposures or germline aberrations and get to the ultimate target for therapy, which may be potentially preventative strategies in an at-risk population? So just to summarize here, we do see, however, and it's not as simple as identifying key genes in different anatomic sites only, because we also have some common genetic alterations across the biliary tree, including in gallbladder cancers, intrahepatic and in extrahepatic cholangiocarcinomas. And that's across P53, PIK3CA, BRCA1 and 2 mutations, both somatic and germline. And interestingly, in this study and in some others, mirroring what we see in other solid tumors of the GI tract, some tumors with high mutational burden associated with high immune checkpoint activity, potentially representing patients in whom a checkpoint inhibitor strategy may be of particular therapeutic benefit. So this slide is deliberately complex because I do acknowledge the complexity of the genomic alterations that have been identified. And this is mirrored in many publications. And our challenge going forward here is going to be to look at this information, really interrogate it, correlate it well with clinical data, and try to identify within this certain patterns, try to sort out, to use our haystack analogy, the wheat from the chaff, to see can we really find out in a given patient with 3, 4, 5 identified somatic mutations, which of those we really should be directing our therapy at. And the only way to do that is to do comprehensive molecular profiling for our patients as early as we can do in their disease course, and to continue on clinical trials and on therapy to identify biomarkers, both in liquid biomarkers and tissue biomarkers, by well-conducted clinical trials in targeted populations with integrated biomarker analysis both on and off therapy. So I show this slide is just a snapshot of our data from Sloan Kettering, because one argument against molecular profiling in biliary cancer is that, well, it's not feasible in the clinic. We don't get enough tissue. The tissue is not good enough quality. It's too expensive to do whole exome sequencing. But actually, we really can identify even the complex genetic abnormalities by using a more targeted and focused genetic profiling platform. And our platform in Sloan Kettering utilizes more targeted exome sequencing of just 410 cancer-related genes. And we profiled over 150 patients using predominantly core biopsies, paraffin-embedded, archival. And so we were still able to identify fusion events, potential alterations in driver genes. And when we look at the data, which incorporates mostly intrahepatic and a small number of extrahepatic cholangiocarcinomas, we really begin to see, I think, the patients sorting out potentially into different groups with possibly different molecular drivers and co-mutations. And what we see is beginnings of some patterns emerging of mutual exclusivity of genetic alterations, especially in biliary cancers, intrahepatic, and also those which differentiate between extrahepatic and intrahepatic cholangiocarcinomas. So it does appear actually that P53 mutations and IDH1 mutations do not frequently coexist. KRAS mutations and IDH1 mutations do not frequently coexist. IDH1 mutations and FGFR2 gene fusions do not coexist and appear completely mutually exclusive. So in fact, while the data is complex and there is work to be done, when we look at it in a very targeted fashion to really try and identify those patterns, we can see patients beginning to fall into certain buckets in terms of molecular drivers, chromatin remodeling, IDH1, FGFR2. And just looking at IDH1, FGFR2, acknowledging that we have work to do in therapeutic targeting of those alterations, they can account for up to 40% of patients with intrahepatic cholangiocarcinomas, really not at all a small number. But it's complicated. So when we plot it in a different way, using this ribbon graph, you can see that there are many, many, many different combinations of genetic alterations, fusion events, tumor suppressor gene deletions, mutations, activating mutations in oncogenes, and they both can have mutual exclusivity and can see co-mutations really across the board. So when we look at this, we can see one of two things. We can see a haystack, that's true, but we can also see potentially a map, because in fact there are some clear patterns here which may be able to direct us better in terms of identifying molecular drivers for a given patient. So how do we separate this? And we do have to probably look beyond just next generation sequencing in trying to identify both prognostic implications and therapeutic implications for these different molecular alterations. This elegantly done study from Japan did also look at whole transcriptome analysis of these patients. And looking at cluster analysis of that, we see that patients do fall into 4 clusters. Looking at survival within those clusters, you can see some difference, albeit retrospective analysis performed to identify this, in terms of maybe a suggestion of prognostic implications associated with different gene expression profiles, and actually also corresponding to different genetic alterations in some molecular drivers. So in cluster 3, we see here. In cluster 3, you see that this actually gene mutation is enriched for mutations in BAP1, in IDH1, and for fusion events in FGFR2. And you can contrast this to cluster 4, which was actually the group of patients with the poorest outcomes. And in that group of patients, in fact, there was seen a high expression of genes associated with checkpoint activation. Immunohistochemical analysis, there was high expression of PD-L1. And this group actually contained a huge number of patients within this group who had hypermutated tumors. So when we begin to look at the data on multiple levels, both gene expression, immunohistochemistry, and looking at the next generation sequencing data, in fact, we can obtain some potential prognostic information and also identify other potential options for therapeutic intervention with potentially checkpoint inhibitors. So I won't dwell on this because we've discussed it already, but the point I want to make by showing this data again is that in fact we're beginning to identify different patterns of molecular alterations in patients from different parts of the world, in patients whose tumors arise from differing etiologic factors. And working backwards from that, our longer term goals here should be to identify what the earliest genetic changes are by interrogating not only the tumor tissue but also the surrounding so-called normal biliary tree, and see are there any early potential opportunities for us to intervene here. Yes, it's aspirational, but we should be aspirational in looking at this data, and we should be aspirational in our longer term goals for our patients, because our ultimate goal here is not just to find inhibitors to bring to the phase 1 clinic for patients who are on 3rd or 4th line therapy, but rather to bring it forward. Can we use this therapy in the adjuvant setting? Can we develop therapies that may be potentially prevention strategies for patients whom we know are high risk, those with liver fluke infections in large parts of the world, those with hepatitis B, those with potentially even germline aberrations in BAP1 or BRCA2 who may have a genetic susceptibility to the development of biliary cancer. And gallbladder cancer, because we know that in this country at least, long-standing gallstone disease is rather the most common etiologic factor for the majority of patients, the sequential genetic changes have been somewhat better elucidated. And they do seem to correspond with what we now see in terms of potential targets for intervention in gallbladder carcinoma, which really do differ quite significantly from those in intrahepatic and, to a lesser extent, extrahepatic cholangiocarcinoma. So we see with sequential changes between chronic cholecystitis, intestinal metaplasia, dysplasia in situ carcinoma, and eventually development of invasive cancer, we see accumulation of multiple genetic aberrations along a variety of pathways, some of which provide potential targets for intervention. And in invasive gallbladder cancer, we see overexpression of Notch, VEGF, HSP90, loss of PTEN, and mutations in particular in the HER2 pathway, along with KRAS MLH1 and some promoter methylation. So can we translate those findings into potential identification of pathways for targeted therapy? Well, certainly there's a lot here to work with. And yes, we know that, as I say, forward-looking, we have a way to go to bring these forward to the first line or earlier of therapy. But certainly one can see opportunities here in terms of multiple pathways activated for which we already have some inhibitors acting on those pathways. And likely the way forward here will not be targeting just one pathway, but rather developing rational combinations of targeted therapies, rational combinations of different targets which may be present in the same patient, so that we may potentially have either sequential or combination strategies. So here we see activation of the HER2 pathway, PI3, AKT, mTOR pathway, VEGF, Notch, and Hedgehog. So in intrahepatic cholangiocarcinoma, which the rather focus will be on today, there are really already quite a wealth of somatic mutations identified for which we have inhibitors in development. And I would argue that while we have seen several negative trials to date over the last 10 years of targeted therapies of biliary cancer, these really are of, I think, a different era, before we had the information that we have now about genetic drivers in cholangiocarcinoma. So now we would not derive a clinical trial where we gave an EGFR inhibitor to a patient with a KRAS or an NRAS mutation. But that's what we did. And we did that because we didn't know any better. But now we do know better. And strategies going forward really should be to make sure that our patient selection is extremely rigorous and that the data we're basing our clinical trials on is based on good preclinical data, good patient selection. And part of that, I think, will be offering profiling to our patients early on in their disease course, rather than waiting until one has failed multiple lines of therapy before identifying what the drivers may be. So these have been discussed before, and I won't dwell on it. But as an example, we know the IDH1 inhibitor is currently in clinic, and now the next generation inhibitor from Agios, dual IDH1/2 inhibitor. Yes, there is work to do, both in identifying radiographic markers of response, as well as perhaps biologic markers of response, but certainly already that is underway. Tyrosine kinase signaling we've spoken a lot about already, and that should be informed and will be informed by our experience in other solid tumours, where we now know which genetic aberrations are associated with both response and resistance to therapy. And then quite unique to the intrahepatic cholangiocarcinomas are the multiple aberrations in chromatin remodeling genes, which offer the potential for intervention with potentially PARP inhibitors and other DNA targeting agents. And I think fascinating is the identification of these chromosomal aberrations, which probably we were missing before with less sophisticated profiling techniques. And really, the more in-depth sequencing we do, the more of these fusion events we're identifying. And good preclinical data has shown that, in fact, for a lot of tumors, these actually are driver events. So not just the FGFR2 gene fusions, but as I'll show you in a moment, also fusions in ROS1 and in NTRK and in others. So ROS1 fusions, these have been identified up to 8% of intrahepatic cholangiocarcinomas. There are agents in the clinic currently targeting tumors which are driven by ROS1 fusions. And these fusion events result in a constitutively active protein. So from a practical sense, and bringing it back to the clinic, if we identify these exciting genetic alterations in patients, do we have anything to offer at the moment on a practical level? And I would say yes, at least in a tertiary referral centre, we now should begin to direct our patients earlier in their disease course towards basket clinical trials, which really incorporate patients with genetic alterations across all solid tumours, rather than focusing just on cholangiocarcinoma, which will allow us to get an earlier sense as to whether these truly are drivers in cholangiocarcinoma and allow our patients to benefit earlier from novel therapies that may take some time to get to a cholangiocarcinoma-specific study. NTRK fusions also identified more recently in cholangiocarcinoma. The true incidence, I think, still somewhat unknown, and likely that some of these have been missed due to differing breakpoints in fusion products. But this also results in ligand-independent activation of the NTRK receptor. So as an example of what we have to offer patients at Sloan Kettering, but of course in all of our institutions, we have similar basket studies available. We have some multi-center studies available of PAN inhibitors, of ALK, ROS1 and NTRK. And this would be, for example, for a population with ROS1, NTRK and ALK rearranged tumors, an example of something we may offer a patient if we identify this as potentially a second-line therapy. Specific inhibitors of NTRK now also in the clinic in phase 1 studies, and some now with specific expansion cohorts for biliary cancers. And important to these, I include this slide really to show that these studies are important to our patients for two ways. Our patients are generous, and we have to remember that. And we frequently ask our patients on these studies to allow us to take biopsies pre-treatment, on treatment, during treatment, post-progression on treatment, multiple blood samples. And it's humbling to see how frequently our patients agree to do this. And they do this not for themselves. They do this for their fellow patients. They do this for us so that we may get information from the tumor biopsy, from those many blood draws that they may wait hours in our clinic to have drawn, to make sure that we learn something from these clinical trials. And we are beholden to our patients to do this. And all of these studies where we identify potentially targetable genetic alterations and we offer and put our patients on these targeted trials, we should make sure that that tissue is interrogated and that the circulating tumor DNA is analysed. And we should use these studies to inform the next trial, because we know that we may not get it right first time and we may not get it right second time. But if we try hard enough and we continue to bring it back to the clinic and we continue to utilize every technique that we have at our disposal, which changes by the year, then we should be able, by the 5th or 6th try, potentially to get it right. And these are exciting times. So I'm not going to dwell on the BDJ398 study because I know that subsequent squeakers are probably going to also discuss this. But suffice to say that those of us who have enrolled patients on this study have been excited by the ability to screen our patients for these genetic aberrations in a timely and meaningful way, and also at the preliminary evidence of some efficacy that we have seen. So I won't dwell on this because you guys are probably all familiar, but we know that this fusion appears to be a driver in these patients and appears to be mutually exclusive with other genetic alterations. And you saw some preliminary results from this study, a phase 2 study in cholangiocarcinoma specifically, and you will hear more about that later on. The IDH1 story, also apparently quite a different population to patients with FGFR2 gene fusions, but activating mutation, which results in an oncometabolite, which we can actually measure in the serum. And interestingly, on the study, the AG120 IDH inhibitor study, we did see, despite not so much radiographic regression, there was, in some responders or longer-term patients with stable disease, a decrease in the oncometabolite that's circulating, which may indicate that we may not always see the anti-tumor activity by simple RECIST measurements. So I won't dwell on those. And then just to finish, we spoke briefly on HER2-directed therapies, probably mostly applicable to gallbladder cancers. There are multiple ways in which we can block HER2, both blocking dimerization, blocking activation of the receptor, direct inhibition of the ligand binding domain. And I just show this as an example of a patient of ours at Sloan Kettering who did have molecular profiling performed for their gallbladder cancer, identified an ERBB2 activating mutation, went on a phase 1 basket study of a HER2 inhibiting agent with remarkably low toxicity profile. An example of both the clinical response, a radiographic response, and of a biomarker response. Yes, it's an N of 1. I do not put this as an example as to this being now moving forward as an approved therapy for gallbladder cancer, but I rather put it up there as an example of what we should aspire to for our patients in terms of comprehensive profiling of the tumour and then having something to offer for potential personalised medicine going forward. So just as a final couple of slides, cholangiocarcinoma is a rare tumour, and this conference has really been wonderful in bringing to the forefront and gathering us together, those who care about doing better in terms of novel therapies. But we are working with a rare tumour type. We have colleagues working in other tumours where molecular profiling has become standard and where it is a billable standard of care procedure. And I would argue that when we compare our data as to what we have identified from molecular profiling of cholangiocarcinoma, it really stands up well beside other solid tumours where molecular profiling has become a standard of care. So in colon cancer potential actionable targets, well, BRAF V600E in colon cancer has proven to be a somewhat challenging target actually in colon cancer, and not one for which there have been a variety of effective or good standard therapies developed. EGFR mutations, well, KRAS mutations, well, I guess KRAS is a negative biomarker. We can argue for that, the main reason that we do this for our patients. But the number of other actual potentially targeted alterations in colon cancer, at least, is relatively few. Lung cancer, again, where this is a billable test and where really every patient in the first-line setting has comprehensive profiling of their tumour now performed. Again, I think our data stands up relatively well beside that in terms of identification of both fusion events activating mutations which are potentially targetable. And maybe this is what we should be striving for here, that hopefully over the next decade, for cholangiocarcinoma at least, and probably intrahepatic cholangiocarcinoma the most promising, that comprehensive molecular profiling may be something that we will be able to offer to our patients as a standard of care so that they may know where they fit along this spectrum. So, Anthony, I argue that if it's a needle in a haystack, it's this kind of a needle in this kind of a haystack, because we have so much information here to work with that really we are charged with making sense of it. And looking forward, I would say, I don't see a haystack, I see rather a rainbow, which our patients with different molecular alterations hopefully can both be unified into a bright path forward of identifying better molecular targets. It's Ireland.
Okay, so doing a rebuttal in this setting may be exaggerated because I think we agreed on many points, as you could tell from both presentations. And I have to confess that I don't see a needle in a haystack. I see a jewel in a haystack. There is a jewel there. It's just the challenge is how really do we go the most efficient way to get to it without wasting a lot of resources of patient lives, etc. Where I agree with Maeve, she used the word aspirational many times, and I have to agree that we're still in that stage. I agree on the diversity of this disease, on having to prioritize these targets, on the importance of well-designed trials, and on the concept of using the broader solid tumor trials to include cholangiocarcinoma patients and learn more about the biology there and move forward. I agree with you when you showed your slide about the profiling of patients at Memorial, that this is feasible in the clinic. My concern is a lot of these patients are not treated in our centers, and therefore this information is being oversimplified, overinterpreted, and overused. I agree on the idea of clustering and using combinations. However, we still need to account for the global changes that are characteristic of this disease, the effect of the microenvironment, the epigenetic changes, the inflammatory changes, the stem cell relevance. Also, we have to think something I didn't bring up in my presentation. Is this a disease like pancreatic cancer where no matter what we do, we're gonna have to always use cytotoxic chemotherapy and learn how these molecular subcategories have to fit along with cytotoxic chemotherapy? And at the end of the day, the biggest challenge we have as we go through this haystack is making sure that what we're doing is relevant, that it's actually prolonging patients' lives and actually potentially leading to a cure, and that it is done in a cost-efficient manner. Thank you.
Questions for both Dr. Lowery and Dr. El-Khoueiry? Anyway. Yeah, please, Maeve. If you don't mind, use the microphone so people can hear you. Right behind you. Sure. Yeah, you want to come up, both of you? Maybe it's a good idea.
It's not so much of a question as a comment. I mean, both really very elegant presentations. But do you see a role for management besides molecularly targeted therapy? For instance, in future, surgical decisions perhaps could be made if there's an adverse prognostic factor. We might, maybe some situations like an FGFR perhaps, that we might see a role for no chemotherapy at all for some of those patients. And do you see much role for implementing this in ongoing clinical trials with whether they involve surgery or prognostic stratification for chemotherapeutic combinations and so on? So in other words, expanding their role beyond just targeted therapy.
Milind, I think that's a great visionary idea. And I think the earlier we implement these investigations, the more we're going to learn about the true biology and its relevance. I think, many of these, especially FGFR, IDH, have some prognostic relevance that seems to be consistent or evolving. How we incorporate this into our treatment algorithm will be a challenge, but I think starting to incorporate it is very important. So I fully agree with you.
Yeah, I think a great area would be to look at the neoadjuvant space, because we learn a lot by neoadjuvant studies of targeted therapy, biopsy pretreatment, the actual tumor tissue that's removed. If we have a signal in the metastatic disease setting, I think it's very reasonable to consider small pilot studies in the neoadjuvant setting, where we get both the prognostic information and we also get the biomarker information.
So we always talk about lumping or splitting, and we typically have lumped, and now we're splitting, and of course, as we split rare diseases, we split into minuscule subsets. So the question is, of course, can we do this just as a few institutions or in a single country? Or the answer is probably no, because we need to get as many of these patients as we can. So how do we do this globally? Because I don't think we can split and split and split and answer the question, because and should we split and split and split? Should we where does gallbladder cancer fit in? I mean, this is, I think, a complexity that we have to talk about if we're going to move the field forward. Your thoughts?
I mean, that's a great point, and that's the challenge, because it's rare, and we have the luxury in big centers of seeing lots of patients, but probably a lot of patients, as someone pointed out, they don't get their tumor profiled at all, right? So collaboration is the key. We have to work together on it. And we have to find out how to integrate this with standard therapy up front, I think. We have to move it earlier. If we wait until patients are already beyond second-line therapy to begin to do molecular profiling, I think we probably missed the boat.
A question for Dr. Lowery. I was wondering about whether you see any epidemiological associations between any of your genetic subsets or pathological correlates.
So we haven't published all that data yet. Our population is pretty homogeneous. So we had a high preponderance of IDH1 mutations, but really a very high number of Caucasian patients. So I think the problem with limited data sets from one center is that we're only reporting our patients. And I think, to speak to the last point, ideally we can have comparisons between different ethnic subgroups, different patients with different etiologic factors, and that's probably where we're going to really begin to see patterns emerging, and then be able to work backwards, I think.
And what about the pathologic features of the tumor? Is there anything evident there? Or?
I would say no, but that's something we're looking at.
Yeah, so I think, I'm sure you're familiar with, but the data that's out there suggests that probably the rate of IDH mutations is lower in Asian countries and much lower in the liver fluke-associated group. Others like GNAS mutations are much more common, it seems, in liver fluke-associated. So.
A quick question for Dr. Lowery. Thank you for the great talk. With the data that you presented from the Sloan Kettering analysis, have you subgrouped it for patients where the profiling was done on resection versus on biopsy for advanced disease, and do you note any differences?
We have, yeah. So Peter Kingham is here, one of our group who's been working with us on this project. So we actually been doing profiling both in the surgical clinics and in the med-onc clinics. So that's something that we've been looking at in terms of profiling from primary versus metastatic sites. And then also correlating that with some of the prognostic information we get from patients who've had resection.
And are you noting any differences in more advanced disease post-primary therapy, anything like that?
So our samples pretty much are all archival. So they're mostly all from untreated patients. And we have seen some patterns of genetic alterations a little more common in biopsy from metastatic sites compared to primary.
Hi, great talk. This is a question for both of you, really. The obvious question always happens with molecular profiling, in that a lot of our patients, as Anthony suggested, they come from the community after some gemcitabine and platinum therapy and such. What are your thoughts on the timing of the molecular profiling, whether it be pretreatment, patients have had Y90 therapy, whatever it is, the role of the timing of that?
I think this is a critical issue that we have to grapple with. We're doing some work in a more common tumor type like colon cancer, where using liquid biopsies, you see clear evolution of these cancers, especially under therapy, including changes in KRAS, HER2, etc. So this concept of tumor evolution and clonal evolution is definitely real. It seems to be real in multiple tumor types. So I think the short answer to yours is yes, this is going to be important. And the question is, can we biopsy the patients when they recur or they have developed metastatic disease for those who actually where we have tissues earlier, and then I think an effort along those lines will be important.
So I just am curious if we think the microbiome matters here. The biliary tract is sterile, of course, until we instrument it. And I wonder, do we know if the disease changes once we've instrumented it and introduced another variable? I don't know how easy that is to answer, but I wonder if that's an important thing we should look at.
Probably is, but I don't know that I have an answer.
Thank you for your elegant talks. Bert Vogelstein has argued that you only need 3 mutations to get a cancer. And that each type of cancer always has those 3 mutations, and they're likely to be drivers. So have we been able to figure out what the 3 mutations you need are for this cancer?
Well, I don't think we know that yet, but I think there's very interesting patterns emerging in terms of mutual exclusivity of genes, which we didn't really, I think, fully appreciate from the earlier studies.
I think we're looking too much at the heterogeneity, and there's probably a core set of mutations that are going to be common.
Right, there are quite a few co-mutations between BAP1 and IDH1, and BAP1 and FGFR2. And BAP1 we think, is the negative prognostic implications. So how that balances against the possible positive prognostic implications of IDH1, that we don't know.
Yeah. Still, the IDH1 still may not be a driver. There still may be a core 3.
Agreed.
I think the challenge from my looking at this is these unifying ones are probably earlier events, right? And generally they end up being harder to target. And what they are here, I think, is still elusive.
Yeah, I don't think we know, because we've never been able to target all 3.